Welcome to the video on how to use the Medi-Cal Chronic Conditions and Medications Used Report, also commonly known as the Polypharmacy Report. This video provides an overview of the Medi-Cal Chronic Conditions and Medications Used Report and aims to support regional center staff in understanding and using the report. This video will cover the following topics: an overview of the Medi-Cal Chronic Conditions and Medications Used Report, medications used or polypharmacy information, and finally, Medi-Cal Chronic Conditions. And now, we'll begin with an overview of the Medi-Cal Chronic Conditions and Medications Used Report. The Medi-Cal Chronic Conditions and Medications Used Report is provided to each regional center on a quarterly basis. The report has two parts. The first part is a Word document that will be disseminated to the Risk Management and Planning Committee Chair and the ARCA Chief Counselors at each regional center, and they can disseminate the report to other individuals at their discretion. The second part is an Excel spreadsheet with identifiable data that can be distributed by secure email to the Risk Management and Planning Committee chairs only. Everyone must use a secure source to distribute the Excel files because the data contains HIPAA-sensitive information. The report draws on Medi-Cal data to identify consumers who receive more than 10 medications for more than 2 consecutive months of the most recent 6 months. It also reports the numbers of consumers who have received care paid for by Medi-Cal for selected chronic conditions. The report has two key objectives: to support regional centers in reviewing potential risks for consumers receiving more than 10 medications on an ongoing basis, and to help regional centers identify consumers who may face heightened risk of unplanned hospitalization and other adverse events because of chronic health conditions. Regional centers can use this report to promote effective medication and chronic disease management. This report is an additional resource for physicians and clinicians. The clinical staff at the regional centers will also receive consumer-level information to follow up on individual consumers or update records as needed. The report is not intended as an indicator of deficient care. Rather, it is simply a resource for clinical staff. What are some of the limitations of the report? This report relies on Medi-Cal claims and encounter data matched to the consumers served by the Department of Developmental Services, DDS. Therefore, only a subset of DDS consumers is represented in these data. Consumers who do not receive Medi-Cal are not captured in these data, nor are Medicare Medi-Cal dual eligible consumers whose prescription drugs and core health care services are covered under Medicare. In addition, consumers who receive Medi-Cal through private managed care plans may not be included in the claims data. Despite these limitations, the Medi-Cal data offers an additional source of information for monitoring the health and well-being of DDS consumers to mitigate the likelihood of adverse events that will result in special incident reports, SIRS. Let's take a look at the medications used or polypharmacy information now. Table 1 on page 3 of the report shows the number of consumers using multiple drugs. Drugs are identified in Medi-Cal claims using the National Drug Codes, NDC, which are Universal Unique Product Identifiers. This measure is designed to focus on long-term polypharmacy issues. For this reason, we do not include drugs taken for only short periods of time, which could occur, for example, as part of an inpatient hospital admission. The first section of the table includes only the number of consumers with at least one Medi-Cal drug claim, with more than 10 days of supply. You should note that this number reflects only the subset of consumers that have Medi-Cal, that have a drug claim, and the supply is more than 10 days worth. For the second section of the table, we display the number of consumers taking more than 10, 15, 20, or 25 drugs for more than 2 consecutive months. For the counts in this section, we distinguish drugs by NDC only. Drugs with different manufacturers or distributors, but otherwise the same, are counted as 2 distinct drugs, as are the drugs from the same manufacturer with the same active ingredients that differ on administration route, such as oral versus intravenous, form, such as tablet or liquid, strength, or packaging, such as package form or size. To be included in this count, an individual has to be taking more than 10 drugs at the same time for more than 2 months. For the second version of the count, we distinguish drugs by active ingredients. For example, 325 mg tablets of Tylenol and 500 mg tablets of generic acetaminophen would be counted only once. For this reason, the second count is almost always smaller than the first. It could be larger, though, because each active ingredient of a drug is counted separately. For example, Tylenol with codeine number 3 would be counted as two separate drugs, acetaminophen and codeine. The worksheet on the next slide corresponds to the second version of the count on this table, where we distinguish drugs by active ingredient for more than 15 drugs. This is an example of the polypharmacy cases shown in the Excel worksheet that gets distributed to the Risk Management and Planning Committee chair at each regional center. The worksheet shows the polypharmacy cases by case manager and consumer ID for consumers taking more than 15 drugs for more than 2 consecutive months. This worksheet corresponds to the second version of the count in Table 1, where we distinguish drugs only by active ingredient for more than 15 drugs. The total number of active ingredients is used to determine the count of drugs, but the different brands, dosage forms, and drug strengths are listed separately here. In determining the count, a drug's prescription must have been for a supply of more than 10 days, but all drugs are listed here regardless of day supply. Only the drugs being taken in the last month of the period with more than 15 ingredients per month are listed. Column 1 lists a 3-digit case manager code that each regional center assigns. Column 2 lists a consumer ID, also known as UCI. Column 3 lists the most recent month in the quarter that the consumer took the drug with more than 15 ingredients per month. Column 4 lists the drug ingredients, drug strength, dosage, and brand. If listed, column 5 lists the national drug code that corresponds to column 4. And finally, column 6 lists the day supplies of the prescription. You are probably wondering, what do I do with this information? Have a physician or clinician review the report for appropriateness. If everything seems appropriate, there is no extra action needed. Please remember, this report is an additional resource for physicians and clinicians. The report is not intended as an indicator of deficient care. Rather, it is simply a resource for clinical staff. Now let's take a look at the medical chronic conditions information. Table 2 on page 4 of the report shows you the number of consumers with chronic conditions. This analysis includes active DDS consumers who reside in a community setting for whom the Medi-Cal data includes at least one claim between the time period listed in the title of the table. You will note that this is a larger group of patients than in tables. Chronic conditions are determined based on the diagnosis codes on claims or recorded as a major medical condition in the Client Development Evaluation Report, known as a CDER. Individual diagnosis codes are grouped into condition categories using the mapping developed by the Centers for Medicare and Medicaid Services. Please note, we focus on only 3 types of chronic conditions that occur often in the population. These are diabetes, chronic cardiac condition, and chronic respiratory condition. Note that these are the type of things we would expect to see recorded under other major medical conditions in the CDER. In this first section of the table, the first row represents the number of any consumer, status 2, who reside in a community setting with any Medi-Cal claim during the period. The second row represents the number of consumers with at least one Medi-Cal claim with a diagnosis for one of the 3 chronic conditions, determined based on the diagnosis codes on claims or recorded as a major medical condition in the CDER. You should note that the diagnosis code could be used on the claim. That does not necessarily mean that the consumer has that condition. The consumer could simply have gone to the doctor to test if they have this condition. In the second section of the table, the first row represents if the consumer was classified in the CDER as having diabetes if they have diagnoses associated with the certain condition categories. The second and third rows represent the number of consumers with Medi-Cal claims as the diagnosis associated with diabetes, but do not have the diagnosis listed in the CDER. The difference between the second and third rows is that we do not repeat the consumers each quarter. For example, if consumer X was listed in row 3 of the previous quarter's report, they would be listed in either row 2 this report if the regional center did not change the diagnosis in the CDER, or the consumer would appear in row 1 if the information was changed in the CDER before the next reporting period was completed. In the remaining two sections of the table, the rows represent the same thing as in the diabetes section, except they pertain to chronic cardiac condition diagnosis and chronic respiratory condition diagnoses. This is an example of the chronic condition cases shown in the Excel worksheet that comes with your Polypharmacy Report. The worksheet shows the chronic care cases by case manager in Consumer ID for consumers with chronic conditions newly identified in Medi-Cal claims but not identified in the CDER. Note that this suggests the condition but should not be considered definitive. For example, it could be a diagnosis tested for but not confirmed. The worksheet corresponds to the counts in Table 2. The numbers listed in the last three columns represent the ICD-9 codes. These are what is on the Medi-Cal claims, but this differs from what is usually in the CDER, which is the ICD-10 codes. Consumers may have more than one condition, as seen in this example, where a consumer has both a chronic cardiac condition and a chronic respiratory condition. You're probably wondering, what do I do with this information? Have a physician or clinician review the report for appropriateness for each consumer. If everything seems appropriate, the regional center can either do nothing or have the responsible regional staff update the CDER information. Please remember, DDS is not requiring regional centers to do anything with this information. Rather, this report is an additional resource for the regional center staff. Table 3 on page 5 of the report lists the top 10 drugs most frequently prescribed to DDS consumers with selected chronic conditions. This table was included in the report at the request of some of the clinicians who reviewed earlier versions. The generic drug ingredients are mapped from NDCs using the RX Norm Current Prescribable Content files from the National Library of Medicine. This data do not map the NDCs related equipment such as lancets or syringes, or for nutritional supplements. We exclude non-mapped NDCs from this table. Here are some important facts to remember about the Medi-Cal Chronic Conditions and Medications Used Report, or Polypharmacy Report. Regional centers can use this report to promote effective medication and chronic disease management. This report is an additional resource for physicians and clinicians. The report is not intended as an indicator of deficient care. Rather, it is simply a resource for clinical staff. Thank you for watching this video. If you have any questions or feedback, please feel free to contact Vicki Wheeler of Mission Analytics Group at vwheeler@mission-ag.com.